Hey there, I just wanted to share a clinical gem from this morning. We had a patient who had a history of a neck injury and they got a surgery for it. Since then, they haven't been able to move well and they're spending a lot of their day in bed. But as you look at them, they have this decorticate posturing where their arm is flexed and their legs externally rotated. When you do their history, it turns out that they were a high school wrestler and their friends always made fun of them because their arms were always a little bit bent and they were always stiff and they were always a bit susceptible to injuries. They also had a history of Legg-Calvé-Perthes disease as a child that had surgical interventions. So as we're looking at it, we understand that there's a probability of a descending corticospinal problem that's giving them low back pain. But the thing is they have this long-standing history that looks like they have a functional neurological problem that also sets them up to this issue. So when I looked at them, I viewed it as they had a right rhombencephalic, left cortical dyssymmetry that was causing tightness, and then overlaying other issues like bilateral frontal activities as well. So their center of pressure was forward and they were having a lot of low back pain. I did some myofascial release on their paraspinals and they experienced a lot of relief, more than they usually experience. And we were standing, but as I did the myofascial release, they pitched further forward. So as they pitch forward, they're gonna have reflexogenic hypertonicity of their paraspinals to pull them back. So you know that you're not gonna get the long-lasting therapy that you want. We then used vertical optokinetics, and I used an optokinetic going upward. Upward optokinetics are perceived as falling forward, and then he had a reaction where he leaned backward and he gained even more relief, and noticed that he was sitting on his heels in that position. So when you combine the myofascial release with the center of pressure changes, you get a different result for the patient. A lot of times that patient would be treated lying down on the table, but I think that lying down on the table, you're not going to get the same postural responses as you do standing, and then you want to cross combine the myofascial treatment with the perception of self-motion with the optokinetic in order to shift their center of pressure. So what we're going to do going forward for them is we're going to have them do different center of pressure therapies with some myofascial work, and then we'll put them on therapies like interactive metronome. But previously, the interactive metronome causes them to have core stability imbalances, which again are going to just be secondary to their center of pressure. So as he gets a little more stable, we'll put him on the metronome activity, and then we'll watch which way he translates. He generally translates to the right, and then we'll give another therapy to counterbalance that. So this is how in myosynaptics we integrate the myofascial treatments along with the neurological treatments in order to work to help our people. If this has been good for you, you can comment below. We'll be watching for that, or comment in the community, and we'll continue our learning process. Thank you so much.